This PowerPoint's over chapter 14. We're going to be talking about cardiac muscle, the heart, and cardiovascular physiology. If we begin with the structure of the heart, we'll find that the heart is shaped kind of like this, right? Where we have a base that is at the top, the apex that is at the bottom, and then the entire muscle of the heart itself is encased in what we call the pericardium. That's a tough membranous sac that protects that muscle tissue and allows for the expansion of the heart during its beating. Okay, the muscle itself that comprises the heart is different from other muscles that we've talked about. It's not skeletal muscle, it's not smooth muscle, it's cardiac muscle, and we call it myocardium. So again, if we look, this would be our base, this would be the apex, and then inside the heart, we have a series of chambers that I want you guys to know. So in anatomy, you would have gone through and been responsible for all of this and probably even more. For this course, I want you to be able to distinguish between the right and left side of the heart. So when you're looking at a picture of the heart, you always need to remember it's going to be kind of in reversed. You have to imagine that you are standing behind this heart and that you're, so if I drew a person, right, here's their head, body, right, arms. Okay, so if we're standing behind the heart like this, then if you put yourself in that person, and this would become the right side of the heart. This is the left side. Now, within these two sides of the heart, we have atrium and ventricles. So the atrium are found at the top. They're the smaller of the two chambers. So blood will enter from the systemic system, from the body. It comes in through our veins through either the inferior or superior vena cava, and it'll enter the right atrium. Once inside the right atrium, it'll pass through the tricuspid valve, that's the atrioventricular valves, into the right atrium, and then it'll be pumped through our pulmonary arteries to the lungs to become oxygenated. And when it's pumped out of the right ventricle, it's going to pass through the pulmonary semilunar valves, go to the lungs, returns from the lungs through the right and left pulmonary veins, and then it'll enter in this time to our left atrium. It'll pass through the bicuspid valve into the left ventricle, and then during the heartbeat, it'll be pushed out of the left ventricle into the aorta, and we'll pass our aortic valve and move into the aorta. Now, how is cardiac muscle different than skeletal muscle? Well, first of all, the cells themselves are much smaller, and like smooth muscle, they just have a single nucleus per fiber. They are connected to each other, so you'll see these, they're like branched and then connected to each other, and at each connection between a cell, we have what are called intercalated discs that hold them together. What this allows is for force from one muscle to be transferred to another muscle. That happens through little gap junctions known as desmosomes, and we can then have a unified contraction through all of our myocardial contractile cells. Additionally, they do have T-tubules, but they are a lot larger and they are branched. The sarcoplasmic reticulum that holds the calcium isn't as large, it's smaller. And mitochondria make up about a third of the space within our myocardial cells. So we have a lot of mitochondria inside these cells. This table, it's actually from chapter 12.3. Where it talks about different types of muscles. This is a great table that summarizes everything between the differences between skeletal, smooth, and cardiac. So make sure you go back, you look at this table, and kind of understand it. Now let's talk about our EC coupling and relaxation and how this differs from, say, skeletal or smooth muscle. So we have an action potential that will arrive at the myocardial cells. So it's being propagated. It got triggered on the membrane of the myocardial cell. It'll move to the T-tubule, just like a skeletal muscle cell. And just like skeletal muscle, it's going to open up a couple of gates. It's going to open up what we call an L-type calcium channel, and we have our RYR channel. Okay, so these are both voltage gated, and like smooth muscle, calcium will enter in from both the T-tubule, so from the ECF, and from our sarcoplasmic reticulum. So we start increasing our intracellular calcium, which causes what we call a calcium spark. At that time, that all those sparks within the myocardial cell, they are summated, and we create a calcium signal, which is then going to bind to troponin, similar to the muscle, skeletal muscle, and will initiate contraction. Okay, so our muscle contraction, the power stroke, and all that is exact same as our skeletal muscle. Really, the only difference is that we're bringing in calcium from both the sarcoplasmic reticulum and from outside the cell. And you'll remember in skeletal muscles, calcium only comes from the sarcoplasmic reticulum. So how do we relax? Well, relaxation occurs just like in skeletal muscles when calcium starts to unbind from troponin. And the reason for calcium to be unbound is that it gets pumped back into our sarcoplasmic reticulum. So we're pumping it in there. We're also using a sodium-calcium antiporter to pump it out of the cell. And as that lowers, as these two pumps lower our intracellular calcium levels, calcium will dissociate from the myosin, from the troponin, which will cause actin to dissociate from the myosin heads, and we'll have relaxation. Okay. We couple this NCX transporter with a sodium-potassium pump so that we don't end up with a bunch of sodium inside the cell, thus altering our membrane potential. So we're going to bring in sodium and then kick that sodium right back out using the sodium-potassium pump. Now, another difference between cardiac muscle and, say, skeletal muscle is that it is a graded contraction. So skeletal muscle contraction is all or nothing, right? Once we initiate it, all that calcium is going to be dumped, and we'll have a full contraction of that muscle fiber. However, cardiac muscle is more akin to smooth muscle in that we can cause these graded contractions where the fiber may contract part of its length, not necessarily the entire length of the sarcomere, to generate varied forces. And this force generation, it really becomes directly proportional to how many of our myosin-actin cross bridges we engage. And that's related to how much calcium we allow in. So if we don't let a lot of calcium in, we're not going to have as many of those cross bridges activated, and the power stroke's not going to be as strong. Additionally, the sarcomere length at the beginning of the contraction is going to affect the total force of that contraction. Why? Well, if our myosin and actin don't have, let's say they don't have enough overlap at the beginning, we're not going to be able to generate as much force. Or if there's too much overlap, we won't be able to generate as much force just because of the physics of how we slide those two filaments past each other. Let's look at their action potential and what that looks like in a cardiac cell. So you notice, first off, membrane potential, much more negative than normal, right? We are actually at somewhere around negative 90 millivolts as compared to some of the other membrane potentials we've talked about. Our threshold is at about negative 40. So when we hit that negative 40, we're going to start opening those sodium channels, and sodium is going to rush into the cell. Okay, so as sodium rushes in, and remember, this is the action potential that's propagating along the membrane. This has nothing to do with the contraction. This is just the action potential that's going to open our calcium gates. So sodium will rush in. Again, these are similar to the sodium gates ion channels that we've been talking about previously. They have activation and inactivation gates. So both the activation and inactivation gate get triggered at threshold, and the inactivation gate, since it's timed, will finally close, and we end up somewhere around a positive 20 millivolts. And then something different happens. What we see is at this point, we have both calcium channels that are opening, so calcium is now coming into the cell, and we're going to have potassium that is going to close. So potassium isn't necessarily leaving the cell like we would normally have in an action potential, and calcium is coming in. And so what this creates is a plateau. You'll notice we're not really repolarizing, we're kind of holding steady. Okay, after a period of time, our calcium channels are starting to close, and we have what we call slow potassium channels that then open. So two types of potassium channels: fast, those close, and the slow open. And now we start seeing more and more potassium enter into the cell, which causes our repolarization, and then we end up back at our resting membrane potential. So this plateau is incredibly important for our myocardial contractile cells. And I'll show you that right here. Now, what we're seeing in these two figures is, in red, we're seeing the action potential, and in blue, we're seeing the muscle contraction. So what you'll notice for skeletal muscle, that action potential is very, very quick. It's happening relatively within 10 milliseconds of time, followed by the muscle contraction afterwards, right? Now, in the myocardial, so in the cardiac muscle fibers, because of that kind of plateau stage that we have, what it does is it increases the refractory period to where now that refractory period pretty much aligns with our muscle contraction and relaxation phases. So why is that important? What does that mean? Well, what this means is a skeletal muscle, we could have another action potential right here, which would follow by another muscle contraction, and we can have summation, right? So we'd have summation in our muscle, and we could reach tetanus. However, in our cardiac muscle, summation isn't really possible. And that's important because we don't want the muscle of the heart to basically have rigor and become fused and tight. Why? Because the heart needs to pump. So this plateau stage in the cardiac muscle is incredibly important for ensuring that we have both a contraction and a full relaxation without any summation occurring in this muscle. Now, in our hearts, we have two types of muscle cells. So 99% of all the muscle cells function the way we just talked about because they are contractile cells. So myocardial contractile cells. They have their striated fibers, they have the sarcomere, actin, myosin, and they contract. But 1% of the total cells that make up our heart are called autorhythmic cells. Sometimes we refer to them as the pacemakers. What's interesting about these cells is they generate action potentials completely spontaneously on their own, meaning they don't need to be innervated to reach threshold. Now, as far as their contractile fibers go, they're much smaller, they're much fewer when we compare to contractile cells, so they're really not generating much force. In fact, they don't even have organized sarcomeres. But what they are doing is propagating the action potential that will spread throughout the rest of the muscle cell. And so that's why we call them pacemakers. They are setting the pace of the contraction of the heart, our rhythm. So if we look at these autorhythmic cells and we look at their action potentials, a little bit different. First off, again, they start around negative 60 millivolts. And what they have is they'll have an action potential, but they also have this pacemaker potential in which they are slowly depolarizing and coming in closer and closer to threshold. So what occurs during this pacemaker potential is that we have these IF channels, okay? I stands for ion flow, so I for ion, F for flow. And these channels are permeable to both sodium and potassium. So sodium and potassium can leak through these channels. Sodium leaks in, potassium leaks out. However, the inflow of sodium is greater than the efflow of potassium out of the cell. So we end up depolarizing. So we start depolarizing, and then when we hit threshold, what happens is we trigger calcium channels to open. When these calcium channels open, the IF channels close, and we have a rapid depolarization of the calcium channels until their inactivation gates close, and then we open our potassium gates to let the potassium out of the cell to cause our repolarization. And again, once we get down to resting membrane potential, our potassium channels will close and the IF channels will open again. So IF channels, sodium and potassium can flow through it, but the effect is that there's a net sodium increase coming in. So more sodium comes in than potassium goes out, and that causes that self-depolarization. So again, great table. It is comparing skeletal muscle and then the contractile myocardium and the autorhythmic myocardium. So what's the differences between membrane potential, what leads up to the threshold potential being reached, what is responsible for the rising phase of the action potential, the repolarization, what causes that, hyperpolarization, what causes that hyperpolarization, and then you can see the relative lengths, action potentials, those types of things. So our pacemakers are found in these little clusters, and this leads to what we call the conducting system of our heart. So the areas that we find pacemakers are in our sinoatrial node, abbreviated SA, the internodal pathways, the atrioventricular node, abbreviated AV, the AV bundles, the bundle branches, and then our Purkinje fibers. So the depolarizations that occur in these pacemaker cells are going to flow along these pathways, and once they kind of move down, they're going to also spread to the myocardial tissue that is found, the myocardial muscle that is found in the atrium and the ventricles. So the pathway that it goes is first the SA node will depolarize, and as that depolarizes, that electrical activity starts to spread out and will rapidly pass it to the AV node, and that depolarization, it's very quickly passed to the AV node because it's going through these internodal pathways via the pacemaker cells found within those. But we'll also have the slower depolarization that occurs in the actual cardiac muscle and the atrium. Okay, once we get to the AV nodes, we're going to move through the bundle branches, then to the Purkinje fibers, and then we'll have that depolarization. It's going to spread from the apex of the heart, so down here, towards the top of the ventricles, and that's what will generate our contraction. So this electrical conduction, all of these nodes have their own kind of rate at which they depolarize. So the function of our, let's say, the atrioventricular node is it's going to take the direction of that electrical signal that's coming from the base of the heart, and it's going to relay it down to the apex and up to the base. So this is done through these internodal cells, like right here. See, it starts up here, but we're going to relay this down through the septum of the heart, where we don't really have any contractile cells, down into the Purkinje fibers, so that when we have a contraction in the ventricle, that contraction squeezes from the apex, so from the bottom of the ventricle, and pushes up. That's important so that we push all the blood. If it pushes from the top down, this is where we have, our exits right around here. If we push from the top down, we basically blow the heart out. Our sinoatrial node is the fastest of all of our nodal pathways. It sets the pace of the heart, which is roughly on average about 70 beats per minute. That's how, 70 times a minute, those nodes are going to depolarize themselves and start generate an action potential. AV nodes are a little bit slower, about 50 bases per minute. And then the Purkinje fibers are the slowest. They would generate their own at somewhere around 30 beats per minute. Now, if we're going to talk about electrical conductance of the heart, we need to be able to understand an electrocardiogram, or an ECG. So an ECG is an image of the electrical conductance moving through the heart. Now, please don't confuse these images with that of a depolarization, repolarization image like we've seen with our action potentials. We generate an ECG by putting leads on an individual that measure the conductance of electricity through the body. So typically we put one on the left arm, the right arm, and on the left leg. And this creates a triangle. And basically between every two electrodes, we would then be able to record whether we are having electricity move across the heart or along these pathways. And what we see is that the direction of a wave that we get is not going to necessarily coincide with depolarization or repolarization. However, it's going to coincide with whether we have current flowing from negative to positive on one of these leads. Now, that's just showing 3 leads. That's the simplest. You can get as many as 10 leads, and it'll give you a lot more accurate view of what's going on in the heart. But here is a standard ECG wave, okay? And we can break this into different regions, right? So we have waves and we have segments. The waves are going to be our P wave, right? Our QRS kind of complex of waves, and the T wave. And then our segments are going to be these flat regions. So, for instance, the P to R is what we call, PR interval. We can have a QT interval. We can have the PR segment. So at the end of the P before we get to, really the Q. That's our PR segment. We can also get an ST segment between S and T. And these are going to correspond to the electrical conductance that is going on in the heart during this time. So what happens in each of these? Well, during the P wave, what we see is atrial depolarization. So this is when the SA node is starting to depolarize and we're generating that wave. Okay, so atrial depolarization during the P through R segment right here. Okay, this is where we're conducting from the SA node to the AV node and to the AV bundle. During the QRX complex is where we have ventricular depolarization. And finally, during the T wave is where we'd have ventricular repolarization. So let's go through these so you can see them with here. So we started with the P wave. Okay, at the end of the P wave, we are now having atrial contraction. So during P is atrial depolarization. This is where we'd actually have the contraction of our atrium. That's going to be in that PR segment. Okay, during the Q wave, you see we've now gone to the AV node, and we're sending it through the bundle branches. By the time we get to the top of the R, at the peak, we're starting to move up for the Purkinje fibers, and by the S, we're now having depolarization of the ventricles. Okay, so depolarization is occurring during the QRS segment. Directly after, in that S to T segment, this is when we would have the ventricles contract. And then finally, during the T wave, what we're having is repolarization of the ventricles. So that shows us all of these, all of the electrical conductance through the heart, and then we correspond it with contraction. So we have contraction during that PR segment. That would be the atrial contraction. We'd have ventricular contraction during the ST segment. Ventricular repolarization occurs during the T wave. When does the atrial repolarization occur? Well, that's going to be recurring right here. So during the QRS, not only do we have ventricular depolarization, but we also have atrial repolarization. Now this brings us to how, when we look at an ECG, we utilize them to see, do we have a normal rhythm, and are all our waves and segments where they're supposed to be? So if we look, here's our normal one. We can see our P, our QRS complex, and the T. And you notice that for each of these, this all looks pretty uniform. So we could calculate what the regular heart rate is by taking, if this is a 10-second interval, we could count the number of full complete waves we have. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 60, 6, because these are 10-second segments. So 12 times 6 would give us 72 beats per minute is what's occurring here. Okay. Then let's say we have something like this. Now we can start asking our questions of what's wrong? What is irregular? So what are we seeing here? Well, we see P waves without QRS interval or a T wave. So typically we ask ourselves when we start looking at waves that don't look right, we say, okay, what's wrong? What are we seeing? First off, is the rhythm regular? If it's irregular, where we're not always seeing the same, we have a P wave without a QRS complex, we would say we have some type of arrhythmia, an irregular rhythm going on. Here's an example. This would be an arrhythmia. We then ask ourselves, are all the normal waves present in a recognizable form? If not, which ones are missing? We then move to, is there one QRS complex for each P wave? If that's true, then we get into something a little bit more complex where we say, okay, is the PR segment, so the spacing between our P waves and the complex, the same? So here we see we don't have a QRS complex between each of them, but even between, say, this one and this one, we can see that our PR segments are different lengths. So something's going on. Even here, really different length. And we can take the electrical events of the heart, and we can now try to superimpose those on the mechanical events of the heart. So there's two mechanical events that we have. We have what's called dystole. Okay, sometimes people pronounced it diastole, but dystole is when we have our chambers being relaxed, and systole is when the chambers are contracting. So when we start out, okay, we're going to be in what's known as late dystole, in which both sets of chambers are fully relaxed. As we start depolarizing the heart or the atrium and then contracting those atrial muscles, we'll go into what's called atrial systole. So the atrium is going to start to contract, which is going to force blood out of the atrium into the ventricle. Okay, for a period of time, when we build that pressure, we're going to force open our tricuspid and bicuspid valves. As the atrium then relaxes, we're starting at the very beginning of that relaxation, we're going to have a moment in which we have isovolumetric ventricular contraction. Okay, this occurs as the ventricle starts to contract. When we generate just enough force to close those valves, but not yet open our aortic or semilunar valves, we have this kind of equal pressure between, right? Not enough pressure to open the semilunar, but enough pressure to close the tricuspid and bicuspid valves. Then, as that force builds and we have that ventricular contraction and ejection, we're going to open up the semilunar or the atrial valve, and blood is going to start getting ejected from the heart. And then the same thing will happen as we start to relax the ventricle. We'll have isovolumetric relaxation, in which we'll close all of the valves again, but blood will be rushing in to either from the pulmonary arteries either the pulmonary arteries or the inferior and superior vena cava to fill the atrium again. Okay, so you'll notice we have both a systole and a dystole for the atrium and for the ventricles. how do we control this heart and this rate? Well, the heart is under autonomic control. So we can stimulate it both by parasympathetic and sympathetic neurons. If we talk about just the autorhythmic cells, right? Stimulation of those autorhythmic cells. So the SA node, if a parasympathetic neuron releases acetylcholine on a muscarinic receptor in the SA node, what that's going to do is it's going to slow down the heart rate. How does it slow this down? Well, it hyperpolarizes that SA node to where it takes a little bit more time for enough of the ions to leak out or leak in, enough of the sodium to leak in through the IF channels in order for it to reach threshold. The converse is true if we have a stimulation by sympathetic neurons. So if the sympathetic neurons release norepinephrine on a beta receptor found in the SA node, that's going to aid in depolarization. So perhaps we increase the amount of sodium that's running into that cell, so we don't depolarize quicker, and that increases heart rate. All of this is being controlled by our cardiovascular center, control center in the medulla oblongata of our brain, right? And so which other side we're using, whether we're using the sympathetic neuron or a parasympathetic neuron, this is what's basically occurring. So the sympathetic, we're increasing either sodium or calcium influx into the cell, which depolarizes it a little bit quicker. So a rate of depolarization occurs, we have a higher heart rate. Or we hyperpolarize the cell with a parasympathetic by increasing perhaps the amount of potassium that's flowing out of the cell, or we decrease the amount of calcium that's coming into that cell, and that hyperpolarizes the cell and lowers heart rate. So that's one way we control heart rate, control our cardiovascular system is through heart rate alone. But there's others as well. We can also control what's known as stroke volume, as how much blood is actually both returning and exiting the heart. That stroke volume can be important for cardiovascular efficiency. We can have a really high or really fast heart rate, but if we're not getting a lot of blood into the heart, it's not doing us as much good. We might be working twice as hard for the same amount of blood. So how do we maintain stroke volume or maximize stroke volume in the heart? A lot of it has to do with the force of the contraction that we create. And we can increase that force of contraction by ensuring that we maximize the number of cross bridges that are able to form during myocardial contraction. So the length of the muscle fiber, and that's largely determined by the volume of blood that's in the heart at the beginning of the contraction. So if we put, for instance, too much blood in the heart, we're going to be stretching those muscle fibers to where the myosin, actin are going to not have as much overlap, and so it's going to be kind of hard to push. Likewise, if we don't put as much in, the heart might not expand to where we can't generate quite as much force. So that stretch is important. So that's one aspect. Another aspect that we talk about is contractility, the ability of those muscles to contract, quickly and with a lot more force. So there's some contractility that we can kind of follow. Additionally, because we know that muscle fiber length is important, what really kind of dictates how much those muscle fibers are stretched is going to be the blood coming back in. And so stroke volume, what we see is it increases, we get more blood exiting the heart and a higher contraction, like contractility increases when end diastolic volume increases. Basically what we're saying there is that when more blood returns into the heart, we also see this increase in stroke volume. What determines EDV, or end diastolic volume? Well, that's the venous return. And venous return is influenced by both the skeletal muscle pump and our respiratory muscle pump. And then all of our blood vessels are under sympathetic innervation. So the heart is going to be under control by both the endocrine system and the nervous system. And if we're talking about contractility of that heart, so the ability of the heart muscle to generate force, the the neurotransmitters that are going to increase that cardiac contraction is going to be epinephrine and norepinephrine. So epinephrine is released by the adrenal medulla, circulated in the blood as a neurohormone. Norepinephrine is being released by sympathetic neurons. And so what happens is we get this ability of certain compounds to increase the contractility of the heart, and we call those compounds inotropic. So if you have an inotropic agent, it has a positive effect on the contractility of the heart. So epinephrine, norepinephrine, digitalis, all of those are compounds, chemicals that increase that contractility. So let's just look in this example right here. We can see how epinephrine and norepinephrine, what they do. Those are going to bind to beta-1 receptors, and then they initiate a couple things to happen. First, one thing they cause is voltage-gated calcium channels to open. And as those open, more calcium can enter in from the ECF, and that's going to create a stronger power stroke, right? We have more calcium that can bind to more of our troponin and make more actin accessible to myosin to grab onto and initiate a power stroke. Okay, so calcium increases from the ECF. More of that calcium will be stored in the sarcoplasmic reticulum. Okay, more that increases the amount of calcium that then gets released during contraction, and we have a more forceful contraction. Right, so that's all happening. At the same time, epinephrine and norepinephrine, they also cause a protein, a regulatory protein, to start being produced called phospholambin. And phospholambin plays an important role in the sarcoplasmic reticulum. It can increase the calcium ATPase activity in the sarcoplasmic reticulum, which means we can pump more calcium back in to the sarcoplasmic reticulum. So we can store more and we can remove it faster, which means that it can get taken out and we can relax a little bit. So what that does, removing it faster, it shortens the amount of time that calcium and troponin bind together. And if we have a shorter duration of contraction, we can kind of reduce, we can generate a big contraction, but then we can release it, relax it really quick, which is important if we want to then have another contraction a little bit faster afterwards. So we have these inotropic agents that can increase contractility and make the heart muscle have a stronger contraction. So this is a great slide that summarizes everything we've talked to about this part up to this point. I'm going to go through it real quick. So if we're most concerned with the efficiency of the heart, what we're talking about is cardiac output. Okay, what dictates cardiac output? Two things: heart rate and stroke volume. So how many heartbeats a minute is going to tell us how much blood gets pumped, right? At the same time, how much the stroke volume, the amount of blood that exits the heart, that gets forced out, that's also going to make up a part of our cardiac output. So these are two things. These are both important to total cardiac output. How is heart rate controlled? Well, heart rate gets controlled by our autorhythmic cells, and those autorhythmic cells are under autonomic control. So parasympathetic and sympathetic. Parasympathetic is going to decrease the heart rate. Sympathetic will increase the heart rate. Okay, so that's this side of the equation over here. On the stroke volume side, now we're talking about the force of contraction in those myocardium. Two things that make up that force. One is contractility. The other is the amount of blood that ends up in the heart, so the end diastolic volume. Okay, we talked about contractility. What increases contractility? Well, sympathetic innervation or inotropic agents can increase the contractility of the heart, that make it beat a little bit stronger. What we hadn't fully talked about is the end diastolic volume. How do we get more blood back to the heart? Well, blood being carried back to the heart is being carried through our veins, and what forces the blood in our veins to return to the heart is the skeletal or respiratory muscle pump. So either our skeletal muscles or our respiratory muscles squeeze those veins to push the blood back. Okay, so that's going to vary with our venous return, how much blood comes back. And we start to get kind of complex in this, not so much on this chapter, but when we talk next week about cardiovascular functioning, and we start getting into blood and blood pressure, you'll see that it gets a little bit tricky as to where we hold the reservoirs of our blood. Do we hold it in the arterial side or the venous side? But for right now, let's just talk about venous return. Okay, how can we increase venous return? Well, there's a couple ways. One is we can actually constrict the veins themselves, make them a little bit tighter. And we'll learn next week that veins and blood arteries, for that matter, are under sympathetic innervation. They are not under parasympathetic. Okay, it's just sympathetic. So the more sympathetic innervation they have, the more action potentials, the higher the frequency, the more they will constrict. The less sympathetic innervation, the more they will dilate. So constricting them is going to increase that venous return, okay, because it's going to kind of force that blood under pressure and put it back. Additionally, our skeletal muscle pump and respiratory muscle pumps can help. These would be under somatic motor control. So somatic motor somatic motor neurons can squeeze, cause some tightening of the muscles, say like in our legs, to help bring the blood up to the heart, or in our respiratory muscles, same thing, to bring the blood back through the pulmonary veins to the heart. So this will increase venous return. It's important that we're able to understand how these things function and what makes them different, and moving forward as we start to build on this, as we add in blood pressure, as we start adding in renal output, those types of things, of understanding this relationship between heart rate, stroke volume, and how they're being controlled. So make sure you read through this in the book, you look at the pictures, the thing, that you understand what's going on. How is the heart rate being affected? Well, it's through the SA nodes and the autorhythmic cells being depolarized a little bit quicker with sympathetic innervation, a little bit slower with parasympathetic innervation. How is contractility being altered? Well, it's being altered by increases in contractility through sympathetic innervation or inotropic agents, by these two issues of increasing phospholambin, to where we're putting more calcium into our sarcoplasmic reticulum, right? Or we're putting more, opening up more calcium from the ECF and allowing that to enter in. That can increase the contractility of the heart muscle itself.